With our next session. The Best of EASL 2025 Alcohol Related Liver Diseases. For the same, can I please invite Dr. S.P. Singh, Dr. Yongi Zabo, Dr. Alexandra Lowe, and Dr. Sandeep S. Sidhu to please chair this session.
I think I must say here that this is the new thing what we started in the PG course this year is the best of EASL sessions. So this is the first time we are doing within the INASL. I think we've done it maybe 10 years back as well, but this is a restart where the best research which was presented this year at EASL will be presented by one of the EASL experts, and then its clinical implication on the Indian side will be discussed by the Indian expert by the Indian panelists. So that's the format for this. So over to you, Chairperson.
So good morning. Welcome to this session, and I think we can get started. So today we're going to have a 25-minute presentation from Dr. Alexander Craig, who will give us the updates on what is new at EASL 2025 in reference to alcohol-associated liver disease. And then it's going to be followed by the presentations from the experts from the Indian side. So whenever Dr. Craig is ready, then we're going to get started.
Sorry. Good morning again, everybody, and thanks again to INASL for organizing this Best of EASL at INASL, and I think it's a very nice way of collaborating between the society. How do we make each other best? How do we best disseminate and integrate knowledge and learning across the world? I think that's the very reason why we're here for, and why we love to have people from India at EASL. We also know that not all can come, so if we can bring a little bit of EASL to INASL, I think that's wonderful. So this is part of this color. EASL colors the different parts of liver disease, and this is steatotic liver disease and toxicity. So what we zoom in on is alcohol-related liver disease and med-ALD. So I picked 5 abstracts which I thought was interesting in the context of what we do, and where there was something which I think is also worth discussing and might have some implications of what we do and how we do it, but also where the field is moving. So 5 abstracts, they will come relatively fast, and I hope that's okay, because I needed to condense a little bit, and many people of the authors were very nice at providing me some slides. The first abstracts I want to point your attention to is this randomized control trial. Corticosteroids are ineffective in individuals with severe alcohol-associated hepatitis and early spontaneous improvement. A multicenter randomized trial done in Belgium was presented by Christophe Moreno. So the setup to do this randomized trial in patients with ALK-HEP, the primary endpoint, and that's important we go back to that, was mortality at day 90, the secondary endpoint mortality at day 28. The sample size calculation, again, important. They calculated that in those patients, we know that already, or we think we know that early improvement is a good sign, and I thought, okay, they might be more susceptible or effective to be treated with corticosteroids, is 140 patients. So this is the study design. They had a screening period, 5 to 10 days of admission. After evaluation, they all have a liver biopsy, and then they should have improvement. And then they're randomized to 28 days of methylprednisolone, 32 milligrams a day, and followed up for 90 days. Then comes reality as any clinical trial. They're wonderful. We know it's the answer to the thing, the one that will cut through all the observational studies that often find things we cannot confirm in randomized trial. So the reality here is that they ended up with randomizing 38 patients to 42 corticosteroids and 32 placebo, and then 38 and 31 completed the trial. These are the key results. That's a survival curve to the left, and I think we don't need much statistics to see that the two groups follow very closely, and both at 90 days there was no statistically difference, and also not in 28 days. So they failed their primary and secondary endpoint. Another secondary endpoint, which we know we discussed for a long time, and sure we'll also discuss today, what is the trade-off here? And here it seems it was definitely not in terms of infections. There was an increased risk of in infections. Let me jump straight to so we come back to the discussion. So the abstract number 2 I want to show you is about self-reported alcohol consumption, discrepancies between self-reported alcohol intake and phosphatidyl ethanol, PEth, in 2,924 individuals at risk of steatotic liver disease. We discussed this a bit yesterday in the MASLD Sympo about the underreporting, and this is then the largest study so far done on assessing this discrepancy. So they aim to compare the correlation between PEth and self-reported in the screening cohort of patients at risk of steatotic liver disease. So PEth is a direct marker of alcohol reflecting the last 2 to 4 weeks of alcohol. So the way it works and why it has a very high sensitivity is that this is a breakdown product of alcohol through the non-oxidative pathway, and then it's embedded in the erythrocyte cell membrane as phosphatidyl ethanol. So it's one of the phospholipids, and that's also why it has this long duration. So that's how it works. It's assessed by mass spectrometry in this study, which is also a very good method. And then for what we know now, it's still evolving a little bit. There seems to be some consensus converging about the threshold, but let's see, it might be different in a few years. But the starting point is that his PEth is very low. It's unlikely people have been drinking the last 4 weeks. I think we can agree on that. It's very high. We can agree, or that's also evidence behind that then it likely have been drinking. And then there's somewhere in between. As again, we discussed yesterday, we like these boxes. They are very useful, that we have some MASLD, we have med-ALD, some ALD. So that's why we want to have these different frames here. And then the study quantify, PEth with liquid chromatography, tandem mass spectrometry, self-reported alcohol intake, and then divided into these 4 groups: low, intermediary, high, and heavy. Also did audit C, the 3 questions, and then divided that into low, intermediary, and high. And based on this, try to put them into the subclasses of steatotic liver disease as we know them as our framework for using that. So this is the baseline group. There was these, almost 1,500 patients in each group, and to no big surprise, since that was basically the definition. The group with alcohol as a risk factor had higher PEth. There were a bit more males there, whereas the metabolic group, the low alcohol self-reported, was less males and a higher BMI and prediabetes or diabetes. If we then come into the core results, this is sort of the bottom line of it. You see on the x-axis, so to speak, the PEth level, and on the y-axis is then the self-reported alcohol intake. And that's what we want to see. To what extent does that concur? And if we start with the part where it definitely does not concur, so we take the top one here, that's in the alcohol predominant, and you can see those that claim they drink very little, basically belonging into the MASLD, and here altogether, a significant proportion, 39%, is underestimating the alcohol. If we move to the more MASLD, or those who were recruited as but based on their metabolic factors, it was 11% that underestimating. But if you want to factor in today what I think would qualify for med-ALD diagnosis, the numbers become significantly higher. Then you're almost approaching 50% in the alcohol group, and what we've seen in other studies, around 30% in the metabolic group. Again, back to the facts that yes, categories are operational, but reality is probably more fluctuating, and very strict borders must be an issue. So that's a thing. Another thing which was an interesting observation is that nobody or very, very, very few reported high alcohol consumption had low PET. I think that's an important clinical takeaway. I'll get back to that because who shouldn't have a PET? If we then look into how does audit C compares, again, how strong is audit C? And that was, I think, a very nice part of this study. See, okay, if you look at the patients with ALD, basically defined that had high, how many of them had with a high audit C also had a high PET? So that was actually quite good concordance. And on the other end of the spectrum, those with MASLD who had a low audit C also largely had a low PET. So telling us audit C is probably much better than we think, and is a useful tool. Of course, there was again this problem with parts of the MASLD spectrum, but again, it seems that even if you're among patients with MASLD, use an audit C, you would actually have captured several of those that would not really be categorized as MASLD. And then metal ALD somewhere in between. So what they end up sort of putting a framework is this, that you need to do three things: self-report, audit C, PET, if you want to have a proper categorization, again, a cross-sectional one. But basically, if you have very high self-reported, you have ALD because they don't lie on high consumption, and then you can avoid spending money on a PET. And if you have low self-reported and low audit C, the probability of having med-ALD and ALD is probably low. And that would actually reduce in clinical practice what they say 40% of PET measurements. And then there are all the one in the middles, and let's focus on them. There's for various reasons on the report. Take away no linear correlation between PET and self-reported, moderate to strong non-parametric characterization. The average underestimated is now, so this is the biggest study, but now we have then studied from thousands of patients. It is around 25-30%. I think that's more or less established across different continents. We need data from Asia, but it might be something around that, maybe higher because you have maybe different stigma, religious reasons. But then the point of reinforcing audit C as a useful tool, and we can improve the precision of subclassification with this. Straight on to the next abstract about fibrosis progression. If we want to do clinical trials in alcohol-related liver disease, we need to do power calculation. How fast does it progress? So this is fibrosis progression rates and performance of biomarkers versus paired liver biopsy, a surrogate for endpoint for clinical trials in ALD and mid-ALD. So there are not many randomized trials with dual biopsy where you allowed to be seen in the placebo arms what is the progression rate and how is the mirroring of changes in biopsy reflected in biomarkers. And I think that's what we want to go forward. What would it take to have a biopsy-based study versus a non-invasive test-based study? All the things that has been built up in the MASH field and has been the ground for designing clinical trials. So it's a relatively small study, 164 patients, 2 years follow-up, all had two liver biopsies. If you look to the right, that shows, again, the Sankey diagram, how patients, in terms of their fibrosis, planar fibrosis stage score, changes over time between follow-up. And you can see there's significant progression, regression. And that gives them this opportunity to see what are the progression rates. So on average, if you take this as an integrated group, it's 0.2 stages per year, one stage every 4.7 years. But I think an important analysis here is that if these patients, among those who don't drink, even though they've had a history of drinking, progression rate is slow. It's around what we see in MASLD, stage 8 years, and probably because of the number small, we normally say 7 years in MASLD. And then if you go to the group that has high alcohol consumption, again, back to what we discussed several times, much more aggressive disease, one stage every third year. And this would, of course, mean something for trial enrichment, for measuring or what you should measure and see if people continue to drink or not, and what you can expect in terms of event rates and power calculation. Then they also did different analysis to see what was associated with risk progression or not, and it turns out that none of these things really popped us up. for either alcohol or steatohepatitis, etc. It could be a power problem or the composition of the cohort, because we know that normally these would be factors associated with progression. Could also be the length of the trial, but we can discuss that. But secondary, again, many of us hope for a field, and now there are already 2 trials, pharma-driven trials in ALD, and we're very fortunate they are not biopsy-driven, so hopefully we can look into a landscape of looking into non-invasive test-driven trials, but that needs to be sorted out studies like this until we have the big pharma ones, see which biomarker can you actually trust most. So what pops up here that correlates best with changes in histology is Agile-3, ELF test, and LiverPro. And if we go into survival analysis again, basically how does this best correspond to, because at 2 years follow-up and 21 patients decompensated died, again with low numbers. But again, in that it turns out that the changes of, in PRO-C3, Agile-3, and LiverPro was the dominant factors. And if you then provide a cutoff, okay, what is a meaningful change? Not so different from what we already guessed, and what has become a little bit the rule of thumb, with at least with TE, that at delta of 30%, both for FIB4, that's actually also turned out surprisingly good, and PRO-C3 and LiverPro. Moving forward here to the Liver Screen Consortium that screened in Europe during a 6-year period, 30,541 patients for liver disease, to trying to see, is we going forward liver disease prevalent enough to be target for screening. So the primary outcome was to assess the prevalence of increased stiffness, liver stiffness defined by liver screening, liver stiffness above 8 kilopascal by FibroScan. And secondary outcome was to assess the prevalence of increased liver stiffness and liver fibrosis in the subgroup with risk factors, obesity, alcohol consumption, etc. The design was a multi-country, multi-center setting, recruiting from the primary care setting. So those with liver stiffness below 8 or normal ALT were not looked further into, and those above were then sent for hospital setting to be assessed for liver disease, further assessed and reassessed their liver stiffness. Then the group defined the criteria to present chronic liver disease as a biopsy. Some of them had biopsy with more than F1, and those without a biopsy, if they have clear radiological signals of with abdominal ultrasound, or a liver stiffness above 10. The second assessment, yes, multi-European, multi-country, European-supported project. Baseline characteristics, yes, it's mainly a Caucasian, so may not apply in an Indian Asian setting, I don't know. A bit more females, average age 58. So bottom line, what was the prevalence of patients with a liver stiffness above 8 kilopascal? It was 4.6%. And according to different cutoffs, we can see it get lower and lower, and that's just again in the setting that 55% of those with an index liver stiffness above 8, it dropped below 8, 55%. So an extension of what I said this morning. So be very careful with relying on single FibroScan assessment. But then let's move into secondary outcomes, looking, see, okay, how is this correlated to cardiovascular risk factors. You can see here dyslipidemia, hypertension, BMI, type 2 diabetes significantly increase the risk of having a liver stiffness above 8. And if you then add alcohol consumption, particularly current, it adds further to our prognostic ability. And then what's also been known, but not in the population setting, is how does it link to the number of cardiovascular risk factors? And again, 1, 2, 3, 4 plus minus alcohol. So if you have 4 plus alcohol, you're really high group, and that's, I thought, probably tells us a little bit of where to focus going forward in this. And probably those with no risk factors and no alcohol is probably not where we should put our money. So prevalence of chronic liver diseases, overall 1.5%, and here you can see the distribution. If they have liver stiffness elevated and ALT, how many of those has chronic liver disease, and those with just liver stiffness above 8, it's only 39% who has confirmed chronic liver disease. And this is the distribution of etiologies. Again, MASLD was by far the most prevalent according to what we have. And now I already showed you the thing around underestimation. There might be some movement between the group, but steatotic liver disease is without comparison the leading cause. This is the happy group that worked on it. And then there's no flowers that grows into the skies. This is also a study that also associated with liver screen, looking at the negative consequences of screening. So the one study showing that screening enhances changes in lifestyle, alcohol, physical activity. On the other hand, we have a lot of knowledge for screening for lung cancer, etc., that is as negative consequences, just enforcing people with anxiety, shame, or anger around this. And we know already with the stigma for liver disease, this could actually be relevant. So they aim to investigate whether screening for steatotic could inflict short or long-term psychological consequences. So try to explore the impact of disease severity on negative consequences of screening. So a single center study, general population 40 to 75 years, dividing into SLD subgroup based on alcohol and excluding those with short time expected survival and known liver disease, and patient come for 1 hour physical examination, medical history, and then have consequence of screening assessed at day 7 and at 6 months. So there are various different questionnaires around understanding consequences of screening. It's a modified one from the lung cancer used in lung cancer screening that has 7 items: self-blame, symptoms, introversion, harm of behavior and anxiety and dejection. So focusing on self-blame, the question on blame, guilt, disappointment, and anger, and they should be answered on a 4-point Likert scale. And I think this is, again, very important that we don't get too enthusiastic and just look at the positive thing of it. So it was a relatively large group of patients with more than 6,000 patients, almost equal gender distribution. 6% had a T above 8, so we're probably informed that you may have liver disease. So in self-blame, 10 to 17% experience negative consequences of screening after 7 days. Here to the left, have you been angry with yourself? Yes, a little. Many patients and a smaller group has felt a lot. Have you felt disappointed with yourself? Have you blamed yourself? And I think a bit more, surprising or concerning thing is after 6 months, 10 to 13% still experience some negative consequences of screening. So was there any factors associated? The risk of having a lot of self-blame is 15 times higher in people with high TE than below TE. We can discuss, because I think that's an interesting concept. Normally you feel lucky that you identify what a disease, and that could be related to some of the stigma associated with liver disease, that those who actually end up with a positive diagnosis or liver disease have a very high risk of self-stigma and self-blame. And I think with that, I will end the presentation of these 5 abstracts from EASL and leave the discussion. Where do I go?
With this, I'd like to invite Dr. Ipan to moderate the next session. That's going to be about the implications of the research for clinical practice in India.
Thank you, Dr. Krag, for that nice selection of the 5 abstracts and presenting them. May I invite the panelists to come on stage to carry forward the discussion for this session. May I invite Dr. Akash Roy to come in. Dr. Deepya Lojan is not able to come in today. Dr. Suprabhat Giri, please take your seats. Dr. Ajay Mishra, Dr. Suvik Mitra, and Dr. Santosh Kumar. Okay, this is how we hope to run it. So in the next 20 minutes or so, we'll have 2 slides showing the same studies again, so we can refresh our memories with what Dr. Krag mentioned. And we'll request 2 other panelists to give their comments on each of these studies. So I will start, and the panelists' names are given here. So may I request Dr. Akash Roy, maybe you can be seated only to save time coming up and down. I'll just run the 2 slides to remind ourselves what. So the 2 questions are, the first panelist will talk about, does this particular research topic impact clinical practice in India? And the second person talks about, does it impact research in India? So the order has changed a bit. The first abstract is on the high prevalence of undiagnosed liver fibrosis in adults in Europe, driven by metabolic risk factors and alcohol in a large population-based study. And so the aim was to study the prevalence of undiagnosed liver fibrosis. Akash, you want to talk about this slides per se? Akash, go ahead.
It's okay, sir. I think sir is already clarified on the entire results and all.
Okay. So this is the key finding of the study, was that there was a high prevalence of undiagnosed liver fibrosis, mainly related to steatotic liver disease, driven by metabolic risk factors and high-risk alcohol use, and thereby there's a need to detect early liver fibrosis and intervene. Akash, your comments, please.
So I think very important study. First of all, perspective. The data of perspective rate on such large registries is important and gives important caveats as to how chronic liver disease in a population is important. Plus, again, it reinforces things which we already know from hepatology settings, GI settings, that if you have got multiple risk factors and if you join them, and with that you have got alcohol, your chances of having that increases. If you translate to Indian settings, where it becomes important is that we don't have any population-based liver screening strategy as of yet. Though it's in a part of a national program, which is now about 5 years old, the implementation of that program towards screening has not been done. So we hardly have structured data starting from a primary healthcare level, then at the district level, then at tertiary levels, and then there are again 2 divisions of urban India, semi-urban India, and rural India. So it will be very important to reapply this in an Indian setting, which measure might be different, whether you're using a FibroScan or PIP4, that again may be different in a city-based setting versus a rural setting, depending upon what your resources are. But we do need to look at what these prevalences are. But what concerns me on the other hand is the last study which sir presented, that if you're going to screen for this, the psychosocial impact of knowing that you have liver disease, which I think we can do this later. But definitely in an Indian setting, we do need to assess for what's the actual prevalence of chronic liver disease in the setting. Only thing is that there's a single point TE measurement, and we know the variabilities of T, that's about 30% inter reading variability. So that can be, but overall, if you see the other study also, the ballpark number is almost the same.
Thank you, Akash. So there are no such data in India, and you feel that there is a need for population-based studies to be done in India. However, the concern is there will be an outbreak of anxiety and in a significant proportion of population, which in European terms is called COS, consequences of screening. It's a new term which we came from that abstract. Thank you. I think Dibya Lochana has not come in today. Would the chairpersons have any comments to make on this particular study, or shall we move on? We'll move on, and at the end, if you have any comment, we'll come on. So I'll request Suprapat his comments on the next abstract. The abstract is on the discrepancies between self-reported alcohol intake and blood levels of phosphatidylethanol in patients, in the subjects who are studied, who are at risk of steatotic liver disease. And just to summarize that in 2 slides, so the aim was to correlate blood levels of this marker of alcohol use with self-reported alcohol intake. And the study concluded that there was modest to poor correlation between the blood levels and the self-reported alcohol use. Suprabhat.
Um, so regarding the clinical implications, there are two implications. One is for diagnosis, another is for management of the patient. For regarding the diagnosis, it will help us in sub-classifying, like we have whether it is steatotic, patient is having either steatotic liver disease or met ALD. So because many a times patients they give underreporting of the alcohol intake, and we find patients with alcoholic hepatitis, they improve, go back, and again they come back with ACLF, and at that time they say that they deny taking alcohol, and we have to do a liver biopsy sometimes, or transjugular liver biopsy, to prove to the relatives that he is taking alcohol. So this is something which can be incorporated into our clinical practice. Only issue is the unavailability and the high cost, because it is in many of the centers it is still not available, and we have to outsource it to a other lab or to a metro city. So many of patients are not willing for that. And regarding the implications for the management, because these patients of who are having a significant alcohol intake, they will require management in terms of psychiatric counseling for de-addiction and for anti-craving medications, which if not given, again they will have a recidivism. And we keep on chasing, his LFT is not improving, we keep on adding more and more drugs, vitamin E, saroglitazar, now GLP-1 analogs and newer drugs are coming. We keep on increasing that by, but we are not going back to the root cause, sometimes because patients deny that. So obviously this is going to be helpful in clinical practice. If we are going for selecting, we need to select our patients where we are strongly suspecting LFT is not fitting into the only MASL criteria. Patient might be having overlap. In that case, I think this is going to benefit us.
Thank you. May I ask Ajay for his comments on how does this impact research in India?
Thank you, sir. I think this test seems to be very promising for the clinical research, as this is phosphatidyl ethanol is formed only in the presence of ethanol in the body. So it is a very specific test for diagnosing the alcoholism. Only issue is that the levels of phosphatidyl ethanol depend on the alcohol intake. Like in mild alcohol intake, the sensitivity is low, but in moderate to high, it is having very good sensitivity, more than 95%, around 90 to 95%. So I think this is only objective test to define MET ALD versus the MASLD or ALD, because we are dependent only on the patient reported alcohol intake. But this will serve as an objective criteria to define in our clinical trials, to define the population of MET ALD versus MASLD. Second is to plan for the studies on the pharmacotherapy in AUD or for the de-addiction purpose. This will again be very important test to see whether the phosphatidyl ethanol levels have come down or not. The only issue will be that the phosphatidyl ethanol is positive only for 2 to 4 weeks. So we have to follow these patients very frequently. Because if the patient is on follow for, suppose he comes in OPD after 3 months, so he knows that he will be caught if he comes drinking within 1 month, because anyway they will become familiar with this test. So we need to follow them very regularly. This is very important. Another caution is recommended is that the phosphatidyl ethanol is formed only in presence of the RBC, because the whole blood is used for it. The serum and plasma will not be able to detect this molecule. So in presence of low hematocrits or low RBC mass, this test can be falsely negative also. The sensitivity will be reduced. So we need to validate this test in the female population, because they have relatively lower hematocrit, and also they have lower cutoff for their alcohol consumption also, because in males we define MET ALD to 20 gram, in females we define it to be cut off to be 10 gram. So in females, we need to validate further. And also in cases of the ALD where the severe anemia is there, severe anemia will further lead to the false negative test. So in those two cases, we need to be cautious about this.
Thank you. I think Dr. Sabo, you had a comment to make.
Sorry, can I add some? I'm not sure I caught your question, but I have some comments about that. This issue, I think, is super interesting and will certainly help us improve the management of these people. However, there is something I don't like with PEth, is that it should not replace the direct interview with the patient. And my personal feeling is that many physicians, probably including myself, are not very good interviewers about alcohol. How much do you drink? Well, 2 drinks, okay, 20 grams. That's not true. So we must be better in interviewing the patients. And one thing which is also missing with the PEth story is that the number of studies giving information about how the patient is interviewed back with the result of the PEth is something which is lacking. Because sometimes people are deniers. They say they don't drink while they drink. And when they feel they can trust you because you ask the question in a simple way, neutral way, not being judgmental, well, often patients are more likely to say, okay, yeah, last time it was our very first meeting together. I didn't know you. Now I know that you don't judge the way I consume alcohol, and I will tell you more about what is my life and what are the reasons for my drinking behavior. So that's the reason why I don't think at all that PEth should be something to classify patients. It's a tool, but we're physicians. So we need to talk to patients and get the best estimation as possible of how the alcohol consumption is. Because the new nomenclature, all papers are on grams per day, not on PEth. So PEth helps a lot. I'm pretty sure about that. I use it on a very regular basis. I would be very cautious about using it as a definition. But I don't know what the other panelists think.
I just have one question. Since we saw that those who had self-reported alcohol consumption, which was high, which correlates very well with audit C, and you sort of don't require a PET in those patients. So as a trial entry criteria for patients with alcoholic liver disease, we exclude out MASLD and MET-ALD. So are these two good enough? If you've got a self-reported alcohol intake and an audit C, for an inclusion, do we actually need PET? We don't need PET.
Maybe so. What I showed there also, of course, it's very difficult to remember it all, but that what the study actually showed was, you say, is that audit C is a very good tool. And that's probably linking very much to what Alex say, that it's part of the interview, and audit C is basically a systematic interview. Of course, you need to build the trust, and what the study also concluded that you should not do PEth in all of them. 40% you don't need it because they have high self-reported. You got the diagnosis, you know what the problem is. If you got low self-reported and a low audit, it also fits. So I think that's the way to find, but it, in my view, now I interpret myself, but I think it's a very useful tool. It's not the magic bullet. Nothing is the magic bullet. That's a relation between the patients, us and the patients, and how we improve their outcomes and quality of life going forward. That's what it's all about. But are the tools that can help that journey be better and more efficient and satisfying for the patient? And I'm sure that PEth can be one of the tools we add to the toolbox. That's also what I do in my clinics. I inform them, I do it, I inform them what it is. And it could also be some of these, what do you want to achieve? Okay, you drink 10 units a day, maybe realistic, you go to 5 units in 6 months. Okay, let's see how that goes. And some like a PEth, we can target for that. So I think that's the way, now we are learning a bit more.
I would request that we'll finish with the panelists first, then we'll come back. Otherwise, we're short on time. Thank you. We'll move on. Next, I'll ask Sovik to give his comments on this poster. Abstract is on steroids are ineffective in severe alcoholic hepatitis patients who have early spontaneous improvement. This was an RCT, and the study showed that there was no benefit in survival at 3 months and at 1 month in patients who received either steroids or placebo when they had spontaneous improvement. Sovik, please.
So this is the conundrum we face whenever we encounter a patient with severe alcoholic hepatitis. Should we straightforward go with steroids? Should we wait? The study, they diagnosed severe alcoholic hepatitis by biopsy. So in Indian setting, it's quite rare we do biopsies in all patients to prove severe alcoholic hepatitis. So it's more likely possible alcoholic hepatitis or probable alcoholic hepatitis. Now, having said that, previous studies have shown if you stratify patients according to rapid risers or early fallers based upon their bilirubin values, so patients who show early fall of serum bilirubin within the first weeks, so probably steroids will not do any benefits in these patients. Interesting data is also coming from India that probably we don't need steroids in the conventional dose of 40 milligram. I can mention the STASH trial where they show you can use titrated dose of steroids or rapidly reduce the dose of steroids. So, but having said that, it's obviously a risk that we carry. Should we wait for 5 days or 7 days to assess his parameters, or should we look at a more earlier stage, suppose a little score at day 3 or 4 to start steroids or not? So these questions needs to be answered.
Thank you. May I ask Dr. Santosh Kumar for his comments on how does it impact research in India on this topic?
Thank you, sir. I thoroughly enjoyed reading this abstract. So my thoughts are, in our clinical practice in India, what we would see is a patient much different from the patient that this abstract is described, because the median DFs here were somewhere around 40 to 50, whereas a severe alcoholic hepatitis in our setting, I think most of us who practice will agree that it's much above 60 and all the way up to 120 or so. And the median males are around 21. Most of our severe alcoholic hepatitis who present as acute on chronic liver failure would have their MEL scores around 30 as well. So in such a patient who presents routinely in our practice, we do not give steroids because they're already fulfilling upper cell ACLF criteria. Some of them do have organ failures. So there's always a lot of contraindications for giving steroids. So multiple studies from Indian setting have shown that more than 75% of patients are steroid ineligible. And among the ones who are steroid eligible also, majority become steroid non-responders after a little score. But the most interesting part of this abstract I felt was in this spontaneously improving patients as well, we do not really see further improvement in steroid arm compared to a placebo arm. So bringing to the big question of does steroid is good enough to be a benchmark of a standard medical treatment against any experimental therapy in severe alcoholic hepatitis going forward? Should we compare the newer therapies with placebo, or steroid continues to remain as a standard medical treatment? That is an important question going forward for research in India as well as worldwide. Thank you.
Thank you. I think Dr. Lowe, you want to make a comment?
Yeah, two short comments. The first one is I don't like the idea that ACLF and ALK-HEP are two different diseases. They're not. They're not at all. When you go to liver biopsy in people who have recent onset of jaundice related to alcohol, and if you look at the fibrosis data, more than 90% of people having MADRS discriminant function greater than 32 have cirrhosis. So all of them have a background of chronic liver disease. And on top of that, because of the classification of the CLIF-OF classification, if you have encephalopathy and jaundice, a certain degree of jaundice, you qualify for ACLF. It's not ACLF 3, but it's still ACLF. So in my mind, the ACLF classification, which is very useful to determine the prognosis of patients, is a prognostic tool, but it's not a different disease. You can have ACLF 2, 3, whatever you like, with infection, with GI bleeding, with ALK-HEP, with DILI, with whatever you like. Eventually, the conclusion may be, unfortunately, that you'll have several organ failures. So that's my first point. And regarding the prednisolone, I'm not saying it's not a perfect drug, but come on, we have RCTs, we have several meta-analyses, not only ours, that of the meta-analysis by Dr. Singh, by Dr. Trivedi, by also, I forget the name of the other one, but anyway. So I don't think we can say that we should test something against placebo in severe alcoholic hepatitis. I'm not talking about non-severe or moderate alcoholic hepatitis, because that's a different story. But I don't think it's fair, because we have a drug which improves short-term survival. It's only short-term survival. It's not an ideal or drug, once again, to test something against placebo based on all the evidence we have for 45 years or something.
Thank you. I'll ask Dr. Sidhu for his, in fact, he only said this slide in. It has got some relevance to the discussion till now. Sandeep.
Professor Lowe, the problem is that what we have seen is among the European literature itself, that if you see the pooled placebo data of 90-day survival, it is 74%. And the pooled and the in this survival data of people on corticosteroids is 70%. There is no difference at 90 days. Whether you give steroids or whether you give placebo, there is no difference at all. So how do we say that we should use steroids as a arm in place of placebo? Number one. Number two, this slide in front of you tells you something distinct. You see, the person on the right hand side is a Caucasian patient. And this picture was shown to me many years by your boss, Dr. Mathuran. He said he went to ILBS and all our patients were on the left side. They were skinny, they had sarcopenia, they had no muscle mass. And these patients have a very poor T cell function. The moment you give those steroids, sepsis comes in and they die within few days. None of the groups present over here in this country, the major academic institutes, we give steroids for this reason. They are already have a large number of patients who have infections, events of infections are already there. And the moment you put them on steroids, they die. Unfortunately, you don't see these kind of patients. You see patients who don't have sarcopenia. In fact, a recent study
Sandeep,
I saw.
So we're running out of time. Thank you for that. So may I just ask for last comments from the chairpersons who have not spoken. So to Dr. Sabo and...
Yeah, I'll answer very shortly. I agree with you, Sandeep. We also have some people with very severe malnutrition in Europe. I know it's unfortunately much more prevalent in India, but two very short comments. The first one is, if you don't screen for infection before giving steroids, you will miss 30 to 40% of infection. So if you get to steroids without doing this screening, you will treat a patient with steroids while he's infected. So that's question number. That's my answer number one. And answer number two is, again, I'm not saying it's an ideal drug. The Lille score helps stop prednisolone if it doesn't work after 4 to 7 days. And we, in a different paper, showed that infection occur after a median of 17 days after the initiation of prednisone. So if you stop the treatment after 4 to 7 days because it doesn't work, it's probably not so harmful. But I agree with you that Indian patients are different from European patients, and we have to be very cautious about that.
So thank you. We'll be running out of time, so I'll ask for concluding remarks from Dr. Sabo, please.
Thank you. So, kind of looking at this, I mean, they're all so important questions, right? And then we want the best for our patients, but really think about it. Even in the United States, 20, 30 years ago, we seen a different kind of outcome of alcoholic hepatitis patients than what we see now. And the big difference was that really the increase in the obesity epidemiology, right? So maybe what you see here in India is not necessarily just the kind of Indian genotype, but I think it's probably the fact that these patients have a different nutritional status than the ones that, for example, we see nowadays, at least in the Western Hemisphere, where there is probably a component of the obesity and metabolic syndrome underlying the alcohol. So going back to the question that was with the PET testing, I was thinking about the discussion. I just wonder, as physicians, should we maybe approach it from the way to tell our patients that, you know, having alcohol is a risk for progressive liver disease, but if you are in the high kind of BMI range, maybe tell them that you have to be even more careful and give some targets of don't drink more than 1 drink a day. And that would help them to understand how far they are from regardless of what they tell us, right? They may tell us that they drink 5 drinks when they drink 10, but they will know what is the differential there. And that's another approach, I think, to consider, because at the end, I think as physicians, we also have to be kind of educating our patients in way of helping them understand the consequence of their actions, particularly with the alcohol, and of course help them to get through that.
Yeah, thank you, Davo. I think now the whole session, we come to the last part, that is open discussion. So we can now have questions from the floor. Yeah, Deepika has been waiting for a long time.
I have a question on this PET levels we want to do in India. It's okay if you do it in the medical colleges and the academic centers because the patient is not paying for it. The moment it comes to private practice and you tell the patient, okay, you're drinking this amount of alcohol, I want to do your PET levels, which is like 3,000 to 5,000, I was Googling. So the patient is going to either check it himself or herself, and we have to tell the patient why we're doing these levels. And you tell them that I don't believe what you're telling me. Do you think patients are going to let us do this because they're going to pay for it? Because, you know, if you Google this, they're going to find out exactly why it is being done. It is better to, I think, talk to your patients and get them to tell you what exactly they're drinking, or the family tells you. Because I don't think in private practice, many patients are going to agree. If they don't want to know how much they're drinking, they will not do the test either. And second thing is, this will be used by insurance companies without telling the patients, and they will use this test, and if the levels are high, they're going to increase the premium. So, I mean, we have to look at the downside of this test also, because it's not going to be very popular in the clinical practice, in private medical practice in India. What are your thoughts on this?
Yeah.
Tracks coming in new, we have to remind ourselves these are only abstract as yet. They're not even full papers. No one is saying we should go and do PET now. It is just that we have to listen to what the late-breaking abstracts are. So that's one general statement. By bringing in best of EASL doesn't say that we are endorsing it. It's just making us think. No one is saying we should start doing this
I
test.
just heard
But it's
Dr.
raising
Rao
many
saying,
questions on that.
I think
Dr. Rao said they're starting
Deepika,
it in AIG.
We'll have to allow others to also ask. Next, I think,
Samir
Dr.
next.
Samir.
Yeah.
And I would request all to introduce yourself before you speak. Yeah, Samir.
Dr. Samir Shah, Mumbai. The question is, how does carbohydrate deficient transferrin compare with PET, and should we sort of move on to PET?
Maybe I can. It's also, and again, if you do the comparative study, you can always criticize them because what is the reference standards? How do you measure sensitivity and specificity when you're measuring something that's not really controlled? So that you can largely not test. So the problem is that it measured a shorter time. And it seems that, again, if you look where I think sensitivity, this reaction can simply not happen without alcohol in blood. So it's a very sensitive test. So that's why, again, I have just for another thing made all the different biomarkers that are possible, direct, indirect, with, without, whatever. I think PET is probably the more useful one because it captures longer one. We got the one for acute intoxication, but what we want to capture, and also given what we discussed yesterday, that these are disease that develops over decades. And that's why I think also the audit, the way we phrase audit, and back to Alex's point about understanding, getting patient information, that's what we want. And where I think CTT, okay, it's better than nothing, but I think it's important add-on in our conversation. And I think it's really sad if we don't do something, because if we don't target this, the thing that kills these patients is the alcohol. So if it's because we're afraid or it's too expensive, whatever, that's sad, because if you then look the other way and they continue to have a lifestyle that will kill them. And I think if that's right with insurance company, but what about smoking or obesity? That's easy to target. They are also very high risk factors for future costs of the health insurance company.
Yeah, Professor Premashish Gaur. Yeah, sir, please.
Yeah. Ipen, I think it's very good that we are trying to find out what is the Indian implication of the research which has been presented in the EASL. It's very good. But my suggestion is we should have a session of innovative areas of research, liver disease in India, which is of importance in our country. To the best of my knowledge, the Indian Council of Medical Research has been emphasizing over the last 1 year about funding projects which has innovative ideas of research, liver diseases, unresolved areas of research in the liver disease in India. And I think if we have a session like that, where you can, you're from the Department of Hepatology, if you can enlighten us, that would give us.
Thank you, sir. I think the point is well taken. Next, Shiva.
Yeah, Dr. Shiva Prasad from Visakhapatnam. My question was with reference to the screening of asymptomatic people for liver disease like was done in that study. Yes, we do know that sometimes if the stigma of finding something is there, but in practice, I think the reverse is also important. If somebody is drinking heavily and then you're doing these screening tests, and when they don't have any symptoms and the tests come back normal, your liver scar, your KPA is normal, your LFT is normal, it becomes really very difficult to motivate them or make them understand the risks of continuing drinking, and they often interpret it as safe to continue whatever they're doing. I think that adverse consequence of screening also should be taken into account.
Yeah, that's always the raising question. Can I answer that? Because we actually did a study on 5,000 patients exactly assessing that. Because that would be the same thing that if you scan a person for lung cancer, whatever, should they just continue smoking? So we did publish a few years back a big study, 5,000 patients. We look also at the consequences of screening. I reference it here, but very briefly. And we see, okay, what we did, we screened all these patients and then we gave them advice. Simple, brief advice about alcohol, diet, and physical activity. And we could see that significant proportion of those, they increase their behavior. And actually the more severe, whatever direction of measured by liver stiffness, the more impactful it was. And we reassessed, and only in a subgroup, but it was a few thousand people again, 2 years down the road, it still has a positive impact on their health, lifestyle, and behavior. So that speaks against your argument that people think, no, I can drink infinitely. Because there you take the conversation that alcohol is not just a liver-related risk, it's highly associated with cardiovascular risk and cancer risk. And that kind of information, they can take a better informed decision. So I think that your argument does not hold.
Yeah, Dr. Rai.
In India, we do most of time SGGT test to find out whether this patient is continuing to having alcohol use. So is there any comparison between this test, PET test, and SGGT in any of the literature?
It's about what is the test references. So that one reference, whatever, maybe a week, 4 to a very short time. And the problem is, again, if you were part of what we discussed yesterday, alcohol intake can be very fluctuating. It's very few people that have constant intake, and there you have a steady state and it's all stable. But if they know they're coming to your consultation, whatever is happening, then people change their behavior, and then they might accelerate back. And that's why in this conversation for the patient, having something that reflects more than it is 2 to 4 weeks, in conjunction with the with the audit that is, let's say, looking into 3 months or even longer, gives you a much better perspective of the integrated burden or impact of alcohol.
Dr. Mishra.
Alexander, the trial with corticosteroids, they waited for 10 days for workup. How many patients died in those 10 days?
Which trial?
The corticosteroid trial.
How many improved during?
How many died in the 10 days the workup period was that? That's important, number one.
I don't have the data.
Okay, second thing, most of these patients, they have adrenal insufficiency, and probably there the steroid works, and probably the short-term survival is better over there. We don't take care of the adrenal insufficiency in these patients. Any trial of using methylprednisolone versus prednisolone?
Very limited data. It seems to be the same, but most trials have tested prednisolone. Just about your very first comment, at least in Europe and in France, you need a couple of days when the patient is admitted to do the liver biopsy. If you do liver biopsy, screen for infection, which is very important, rule out HCC, which is also very important, and get an idea of what is the family of the patient, the family support, etc. But if the patient is too sick, can't get prednisolone because his probability of getting infected is very high, he has his first liver decompensation and has a good family support, etc., we generally don't treat these people with prednisolone and we go to early liver transplantation. But you need a minimum of, let's say, 5 to 7 days to get all the information you need to manage the patient properly.
My question is to Dr. Dr. Alexander Craig. PET test, is it pathognomonic of alcohol consumption? Does it have any false positive and negative? Number one. Number two, there are people who are rapid metabolizers of alcohol. That is the difference between male and females. And 1 in 5 out of the alcoholic patients will develop damage to the liver. Does PET reflect that?
So the last question is very clear. Of course, PET does not reflect liver damage. But one of the studies I also showed yesterday that it has prognostic value. So if you already have a known liver disease and you have a high PET, that's interesting. That this has a high prognostic performance than, let's say, self-reported. Then there's a thing about the false positives, and we get that questions once in a while. Then people say, no, I wash my hands, did a lot of all these things, but you don't absorb that much alcohol. And then there's a whole thing about the microbiome, the gut-producing, the alcohol-producing box. You know, a lot of this is done and metabolized very fast. So this can probably generate very low levels. That's also why I say PET below 20. What does that mean? Nothing, probably. So that's the way. It doesn't relate. It's a strong prognostic. In people with liver disease, false positive probably don't really exist. And I think false negatives, I think because it's so sensitive. So for these reasons, as with the knowledge we have now, that's also why it's kind of my favorite mark, and many of the others have different kinds of weakness. And again, it's such a sensitive issue. It's nice to have a very sensitive marker. What's more different is the breakdown. So actually the half-life of PET can change. So it's not this, people say 4 weeks. No, that's wrong. Biology is never like that. Not like they suddenly then die everybody after 4 weeks. So it's probably more like 2 to 4 weeks. But in essence, we don't know. And also, which I think is very important, is to understand the PET you measure in a cross-sectional setting. So it depends. Every time you drink, it sort of bubbles up, and then you drink again and again, and then you stop drinking. It sort of starts wearing down. So where do you capture the patient on this journey? So that's why it needs to be triangulated, integrated with the audit and self-reported.
Thank you.
Thank you. I think we'll close the session. It's been a very interactive session, and I thank everyone for participating.
For a good picture. Nice to be elaborate. I'll request you to be on the center of the stage for a group picture. Wonderful.